Liebe Kolleginnen und Kollegen, liebe Freunde des Amos Studientelegrams, Marcus at home welcomes Professor Nassim Kamar at Toulouse, France, with whom we would like to discuss his recent New England data on triple SARS-CoV-2 vaccination in transplant recipients and his NDT paper on triple vaccination in dialysis patients. It's a privilege to have you. Thanks a lot for taking your time. My co-moderators today are both from Saarland University Medical Center, Sören Becker and Martina Seester, who are both also experts in this field. So I'm the only non-expert. My name is Gunnar Heine from Araplesion Markus Krankenhaus.
Yeah, welcome, Nassim, to have you here amongst us. So Nassim is a nephrologist and he is head of the nephrology organ transplant unit at Toulouse University Hospital. And he is a world-known infectious disease specialist. And today we will talk about COVID-19 vaccination. But you should know that he is also an expert on CMV infection after transplant, BKV virus infection, and most particularly, he is a world expert in hepatitis E infection. So in case you have questions thereafter on hepatitis E, he is the person to ask. So, but today we will deal with coronavirus vaccination in transplant recipients, as Gunnar already announced. And yeah, that will be the topic of our talk. And Gunnar, you are the one to start with.
So my first question is actually a curious one. So we always look to France and we are kind of envious with all the strong data that come from France. And our personal opinion is that you kind of headed forward in some ways. And to our best knowledge, you are the first country that actually asked patients to go for a triple vaccination if they are immunosuppressed. So would you have any ideas why France is kind of before all the other countries? Are there any underlying reasons for this?
Yeah, thanks very much for the invitation and for the kind introduction. So the Francophone Society of Transplantation had asked the national authorities to go to the third dose. And I can tell you in the beginning, I was not very optimistic and I was not, I didn't want them to go straight to the third dose because in the beginning, we were missing vaccines for the other patients, so there was a genetic problem. And secondly, we didn't have the results of the second dose published yet. So I was just asking to remain on the 2 doses. But finally, they were able, the Francophone Society of Transplantation was able to push the health authorities to go to the third one. And when they decided to do it in the third one, although there were absolutely no data, they recommended it in transplant patients, in dialysis patients, and all immunosuppressed patients, whatever the autoimmune disease was, or even if they have a cancer on chemotherapy. And we received a recommendation from the authorities. If I remember well, it was a Sunday evening at 11 in the evening, telling us that we can go to three doses. And during the night, when I woke up the day after, I had already 20 emails from my patients asking me when they can go to the third dose. So although I was not really pushing for the third dose, I had to do it because it was the recommendation. So we organized everything and they went forward to the third dose. So this is why they moved from the second to the third dose. It was really pushed by the Francophone Society of Transplantation.
And may we ask you just to summarize your findings both on dialysis patients and particularly surely on transplant patients for our colleagues in Germany, Austria, and Switzerland?
Yeah, of course. So I'll start with the transplant patients. With the transplant patients, when we had when we started to vaccinate our patients, we were really quite organized, at least in our center, and we sent a text message to all the patients and asked them to either to come to the hospital, to be contacted by the hospital, or to a vaccination center. And on the other hand, the Francophone Society of Transplantation had recommended to do biological monitoring for antibodies and all biological things all around. So this is what we started in early January. And when we did the 2 first doses, we had observed in our first paper that we published in Annals of Internal Medicine that the seroconversion rate was quite low. It was less than 30%, so it was 28%. So when the third dose was recommended, we invited all the patients to get the third dose, and the majority of my patients had already get the third dose. So we have an update paper that is now submitted for publication with no more than 400 patients, and there are nearly now more than 800 patients had get the third dose. And in the New England Journal paper, we had observed that after 2 doses, the humoral response was around 40%, and it went up to 68% with the 3 doses. So it's still much better than 2 doses, but it's still very far from what are observing in immunocompetent patients. And what's interesting is to see that the titer, the antibodies titer is not very high in all patients. There are some few patients in whom the titers are quite high, especially those who were positive after the second dose and they were really boosted by the third dose, while in seronegative patients who became positive after the third dose, the titers were quite low, relatively low. It's around 600 units. And currently we are checking in this population for neutralizing antibodies, because we have not just to look for the humoral response, we are looking for the neutralizing antibodies, and hopefully we'll get all the results soon. What we didn't do is the T-cell response. We didn't look for the T-cell response, at least in this population, and this is an important point. There are now conflicting data, because on patients receiving Belatacept, we did it in a small number of patients and we didn't have any humoral response or any T-cell response. So patients receiving inhibitors of the second signal do not respond at all. So even with the third dose of vaccine, we went up to, I think, 30%. So it's really, really low. But for the other patient, calcineurin inhibitors, we do not have yet. We have some ongoing studies, but on small number of patients for T-cell response. What we did in dialysis patient was absolutely the same. We have nearly 160 dialysis patients on dialysis in the hospital, on hemodialysis or on peritoneal dialysis, and we offered them the 2 doses. And we found that the seroconversion rate was around 85 to 90%. And in some few patients who remained seronegative despite the 2 doses, we gave the third dose, and we obtained a seroconversion rate in nearly 45% of patients who were already who have been seronegative. Interestingly, in this paper, we observed that the non-responders among dialysis patients were patients who are more immunosuppressed, who have been already transplanted, or who have had a non-renal transplant, such a heart transplant patient or liver transplant patient. So we go back for the same issue. It's transplant patients given immunosuppression have relatively bad response compared to the immunocompetent patients. So I currently, at least in my center and several centers in France, we are not giving the triple dose to all dialysis patients. I'm not sure it's important to give it to everybody. This is why even the recommendation had a little bit modified, and the Society of Nephrology and Dialysis said it's up to you, up to each doctor to decide if you give the second dose or the third dose. So what we are doing is we are checking for the serology after the second dose. If it's already positive with a high titer, I do not give the third dose. But if the patient is seronegative or with a low antibody titer, I give the third dose to dialysis patients. Conversely, in all transplant patients, we are giving the 3 doses.
And I would have one other practical question before switching the mic to the other 2. So in clinical practice, we do have quite a lot of patients who did have COVID-19 last year and to come to dialysis now. And according to our, at least German recommendations, we would just give 1 vaccination to these. What do you do in France with these people? Do you go for 2 or for 3 vaccination? Do you check the antibody status? And particularly, do you wait after COVID-19 for half a year, or do you go directly to vaccination?
Yeah, so in immunocompetent patients, non-dialysis patients, it's recommended to wait for half a year, for 6 months. In dialysis patients and in transplant patients, it's recommended to wait for 3 months after the COVID-19 to start the vaccination. The main question is, should we do 2 or 3 doses? We are not giving one dose to these patients. We are giving at least 2 doses. And the question of the third dose, it's still unknown, so we do not know. So what we are doing is we have very few patients. So we are checking the antibodies and we are deciding case by case. But I'm not sure that we have sufficient data to give any recommendation to give 2 or 3 doses in patients having been infected less than 3 months earlier. So I don't know. We are just doing case by case, at least in my center.
Okay, Nassim, you just outlined that you give the third dose, I guess the same vaccine as the two previous ones. Have you or the French Society ever considered alternative ways of boosting immunity? Because this is currently discussed in Germany also, like a higher dosage of a vaccine or maybe also combinations of existing vaccines. So your recommendation was just the same vaccine applied a third time?
Yeah, and in France, since the early when the vaccination campaign started, we have been asked to give the mRNA-based vaccine to all our patients. So started, and we didn't have, at least in my area, we didn't have at all the Moderna vaccine. We have only the Pfizer vaccine. So we gave Pfizer vaccine to all the patients. And during a short period, it has been recommended to give the AstraZeneca vaccine, and finally they stopped it very rapidly because of some side effects, and so we moved rapidly. So I have very few patients who started with the AstraZeneca vaccine and who moved afterwards to the Pfizer or the Moderna vaccine. So the large majority of my patients had received Pfizer, very few Moderna, and I think less than 10 patients who get the AstraZeneca and who continued with another vaccine. I didn't check the results of these patients, but only 10 patients. So.
Okay, yeah, that's interesting. Because there are certainly more being vaccinated with the vector vaccine here in Germany, that's for sure, yeah. So given
and
that
I think it will be very interesting to have a look on the effect of starting with the vector vaccine and moving to the RNA vaccine.
Yeah.
I'm wishing to have the data, but I do not have the patients.
Okay, yeah.
So Martina will help with the data.
We in fact have some in our center, but given that the distance between the first and the second is so long after vector vaccination, that takes still a bit time, but we are at the moment in the progress of this, yeah. So, but I would like to come back to the analysis of the titer. So you said the transplant recipients were not tested for antibody levels, but would that be reasonable in your opinion, because you can probably predict who will probably benefit from an additional vaccine, maybe if there are low levels, if that can be boosted, or even provided if there is no shortage of vaccine, that you could apply a fourth one to boost something?
Yeah, I didn't say that we are not testing the patient. We are testing absolutely all the patients before and after the vaccines. But we are not looking for the titer before giving the third boost. Because since it has been recommended, I can tell you that all the patients have asked to have the third one, whatever the title was. The question now is who will receive the fourth dose? Is it the patient who are already very high or not? So now we are start thinking about the fourth dose. But the fourth dose, it will be only in seronegative patient after 3 doses, or a patient who have seroconverted at the third dose and with a very low titer. Mm-hmm. So now we are checking the titers in all the patients, but for moving from 2 doses to 3 doses, we had to give it to everybody because all the patients wanted the 3 doses.
Okay, yeah, that's interesting.
So yeah, and we will be able to have a look and to see what is the predictive factor of response. And in my opinion, the most important question will be for how long the antibodies will persist. This is the next question, because probably I don't know if in 3 months or 6 months, I don't know what will happen.
Mm-hmm. And I mean, you in part already touched the issue with dialysis patients who responded actually very well. So is that recommendation reasonable in your view, or would you stick to this recommendation of having these patients vaccinated 3 times or even more?
No, in dialysis patients, I think 2 doses will be sufficient in the large majority, especially those who are not receiving any immunosuppression. It's like the general population. I'm not sure that there's a huge difference, except in patients who have been transplanted few months or have returned to dialysis few months earlier, can be considered as transplant patients or those with an ongoing transplant. Otherwise, we are just giving 2 doses. I am not sticking to the 3 doses in dialysis patients.
Yeah, thank you.
And the question will be, once they are grafted, what will happen when we will start immunosuppression? For how long the antibodies will be remain positive? And if we have to do a recall, and when should we do it? So, well, we will have some more papers to do.
Right. So thank you very much also from my side for being here with us today. I would have 2 additional questions, I guess, with regards to how many vaccine doses need to be applied. The first one is, I think, has been partially answered. There's much debate about whether general population or all healthcare workers, for example, should undergo a 3rd dose in the foreseeable future. I'm not sure whether data are sufficient to conclude on that, but what would be your feeling?
For health workers, the main problem is that all the health workers are not already vaccinated once. So this is the main problem. And currently in France, perhaps they will ask to be mandatory to be vaccinated to work in a hospital. Because in my hospital, for example, we are around 75 to 80%. And overall in France, we are around 60%. I'm not sure that we should do it 3 times. The question will be, at least for a primary vaccination, the question will be if there will be recalls afterwards. I don't know at all. I don't know. Probably we will have to do it. I don't know if it's once a year, once every 2 years. I don't know. But I'm not sure that in immunocompetent patients receiving for the first time the vaccination, in my opinion, 2 doses should be sufficient.
Okay.
I don't know what you're thinking for Germany, but
I would personally also feel pretty similar that 2 doses might be sufficient, actually, but I think the debate is still far away from being conclusive. So, but another question would be to switching from 2 to 1 vaccines in different instances, because I've been contacted recently a lot by people who are treating, for example, persons with autoimmunological diseases, who are telling me, well, they would rather not like to go for a 2nd vaccine because they had maybe an exacerbation of their autoimmune disease. I'm not sure whether really triggered by the 1st vaccine or at least temporary relatedness to the 1st vaccine, and who then got antibodies checked, had very high antibody titers, and are now facing the challenge whether the doctors should try to convince those persons to get a 2nd vaccine, and that's, I think, the personal medical decision. And the second one is also for proof of vaccination. I think this group of patients is not really covered by all recommendations with regard to green EU certificate, etc. so far. So I don't know whether you have made similar experiences, or what would be your feeling on that aspect?
Yeah, I understand the risk of boosting the immune system in patients having already an autoimmune disease. For example, 2 of our patients experienced an acute rejection, not after the 3rd dose, but after the 2nd dose. And both were kidney transplant patients, and in the 2 cases, the acute rejection was quite severe and required T-cell depleting agents afterwards. So it exists, and we have observed some relapses of some glomerulopathy, like IgA nephropathy or membranous glomerulonephritis. It exists, but it's, in my opinion, it's still a minority of the patients. So I am still convinced that we should propose 2 doses even in these patients, because they are already receiving immunosuppression, and I am not convinced that they will have a very high titer of antibodies. And the second question is to have a look on the neutralizing antibodies, if they are neutralizing antibodies or not, because if they are not neutralizing antibodies, it will be they are not absolutely not covered. So in this setting, I stick to the recommendation to give two doses.
Okay, thank you very much. And last question from my side would then be with regard to checking antibody titers versus checking T cell function, which is, needless to say, much more difficult to do in clinical routine. But what would be your feeling in should we fully rely on serological testing, or rather try to get the other aspect of cellular immune response measured somehow in clinical practice?
In the ideal world, I say we have to do both, because we will have the two responses, the T cell response and the humoral one. For the moment, as I'm not an expert in the T cell response to the vaccination, but what we observed in the published literature are really conflicting data, because there are the paper published from the group of Juan and Jason that show that they have a relatively low humoral response, but a quite high T cell response. As I told you, we tested it in patients on Belatacept. It's probably not the good group because they are not answering to anything, but was very low. In my opinion, if it's feasible, we should do it. And I'm sure that Martina is doing it because she's a specialist of T cell response. And I think it's very important to say, because it will be very surprising to have zero T cell response, also without a humoral response. So probably they are a little bit protected, but we do not know what, for how many and for how long.
Yeah, so lots of questions still to be answered.
Yeah.
Thanks.
And we are happy to have the French colleagues, because you do all this clinical work. And again, from time to time, we really get kind of envious of you, because not only in the field of COVID-19, there are many fields of clinical nephrology where French nephrologists are leading. And we saw strong data in recent months on renal replacement therapy in acute kidney failure. We saw strong data on membranous nephritis. So really, thanks for all of the work. So we invite all our colleagues not only to listen to you, but also to read the papers, which are linked to our YouTube video, and take your time. It's really fascinating to read your results. Thanks for your work, and have nice holidays, because we know that you're leaving for 1 or 2 weeks of holiday now. Yeah? Thank you.
Thank you very much. Thank you for the invitation.
Thank you.
Thank you. Bye-bye.